Good morning, everyone. We're going to get started because I want to respect everybody's time today. So I'll give people a minute to get their seats. Those in the room are drinking coffee and eating bagels. Those at home, I hope you're hydrating. So first of all, thanks for those of you who are in Zoom land and put your name in the chat. And we have people as far away as Wisconsin, New York, um, Oakland, Oklahoma, Arkansas, New York, Sacramento, Pasadena. We have people from everywhere, even the National Association of Counties and universities. There's quite a few university folks on. So thank you all for coming near and far. And even Louisville, which is a new one for me. I haven't seen that in a while. So again, thank you for coming to the Spring Fall Vaccine Forum. We call it Let's Rise because there is a CDC initiative that helps support us catching up vaccines across the lifespan. So we've themed our entire effort for the next few months on this. And by way of introduction, I'm Tracy Veal, and I help support the Immunization Coalition of Los Angeles. And I am here as a facilitator. And I'm going to introduce our chair, Carrie Hurley Kim, Dr. Kim. And she may not want to say a few words, but she has been with ICLAC probably quite a number of years. And I also want to introduce some other steering committee members for ICLAC because the Immunization Coalition of Los Angeles has this acronym ICLAC, which nobody knows how to pronounce, right? So I'm going to keep saying it so you guys get it. It's like quack like a duck. So it's ICLAC. We also have Dr. Richard Dang in the room who will be presenting later today, and he's our vice chair. And we have Susan, and she's from the Los Angeles County Office of Education, and she's also one of the steering committee members. And we have Elsie Nash, who has a variety of organizations she supports, including Immunize LA Families. And I think there's a couple other steering committee members. Azita, who's just left the room, is kind of in charge of us. So there she is, she's there. She kind of is in charge of us for Los Angeles County Public Health. And so we'll get started with that. And I want to also introduce Dr. Andrea Kim, who is our fearless leader for vaccine preventable disease control. And I don't know if you want to say anything today, Andrea, but I'm going to give you the floor for a few minutes. And I also want to acknowledge National Public Health Week for all of those who have toiled and labored in public health and for all of those who have supported us. Thank you for Public Health Week. And in acknowledgement of that, for those in the room, I did put those hand sanitizers that say public health out. I put hand fans that say public health out. And I have water that's branded public health, so you will remember it's Public Health Week. And there are little goodie bags in the back for you to take one of those stress balls and some of those things with you when you go. Okay? Thank you for that, and I'll turn it over to Dr. Kim. She has her own mic, so go ahead. You can come up front so they can see you if you'd like. Okay.
Thank you, Dr. Veal. I just want to say thank you to everyone that organized this meeting, and how gorgeous is it here. For those that are here, thank you for all the preparations, all the time that was spent for this meeting. I'm so excited to be here. As you know, I've recently joined the Vaccine Preventable Disease Control Program as the director. That was about 9 months ago. And so I've been to the last three, I think it was 3 forums. When you started off that, you just kind of relaunched the forums. It's been incredible just to see the growth and to have the collaborations with all of you. I believe on Friday, we ended the public health emergency declarations for COVID. I mean, it's been an incredible 3 years. You all have been partners with us in this fight against COVID. You still continue to be. Just want to thank everyone, all that hard work. I know we are all tired, and we all know that the emergency actually isn't ended. I mean, COVID is still here. But I do want to thank you for all that, just the work, the time, the energy that you all have placed in this partnership with the county Department of Public Health. We couldn't have done this without you, not just for COVID, but for all vaccines. So I'm excited to hear what's in store for today. Again, thank you for your partnership.
Okay, now we'll have Azita Magana, who's going to come up and speak briefly.
Good morning, everyone. My name is Izita Magana. I'm the Director of Vaccine Confidence for the Vaccine Preventable Disease Control Program at Public Health. And I just wanted to say a quick thanks to Tracy. And I remember when she came on, the pandemic was just getting going, I think maybe a few months, and we met at a cafe, and I don't even know if I'd showered. I had jeans on. I just like hadn't washed my hair, and Tracy showed up looking like this. And so, you know, at county, you know, I say like we do a little check. We have internet, we have running water, and we're like, we're good to go. And I just appreciate so much the different perspective and what you bring to this field of immunization. We are tired. We're really tired. We have vaccine fatigue. We have pandemic fatigue. And unfortunately, too, we know that there's been a spillover of hesitance from COVID vaccine to our routine and recommended vaccinations. So it's a critical moment that we kind of are able to shift our energy and address our community's needs. What I love about these declarations is it is spring, and the emergency is over, even though we know, as Dr. Kim said, there's lots still going on and lots of COVID issues to be continued. But it is a reminder that it is spring, so we get to celebrate that. And also, Tracy, what I love is that you know, she sees the whole person. We're not a world of the vaccinated and the unvaccinated. We're people who live with seasons and holidays and all kinds of things. And thanks for helping us remember that we're living in a full world that goes beyond, with a lot of needs and lots of things to celebrate. And so I just always appreciate the joy and perspective you bring to our work. And so thanks everyone for being here today, and I'm looking forward to hearing all the good presentations and to collaborate with all of you ongoing. Thanks. Are you coming up, Carrie? Come on up, come on up. Thank you.
Okay, and a couple of words from Dr. Carrie Hurley Kim, who's our fearless chair of the Immunization Coalition. And over the last 3 years, we went dark during the pandemic, and that's when I came to relaunch it. So we're still in relaunch mode. It's the first year, so I'll let Dr. Kim have a few words.
Thank you so much. Thank you all for being here. I really just wanted to echo the previous sentiments. I think during COVID, as Tracy said, we were pretty dormant. At one point, my department chair asked me, like, are you sure this is where you want to spend your service time? And I'm really glad that I, you know, stuck with public health and with this organization, because we've come so far in such a short time. We've had, you know, grant money coming in almost faster than we can spend it, but Tracy always finds a way. So we've also had questions from a lot of outside organizations and other coalitions asking, you know, how did you manage this relaunch and get to, you know, where you are today? And the only thing I can say is you have to find a Tracy. So we definitely could not have done any of this without her, and I'm really excited for this 25th year that we have coming up.
Okay, so part of this vaccine forum is we celebrate our 25th year of the Immunization Coalition. And our agenda today really reflects the State of Immunion from Jamie Vickery, who is going to be here from Zoomland with Vaccinate Your Family. And then we have Alexandra from Johns Hopkins University, and she's going to talk about some of the tips and tools for managing misinformation that's impacting all vaccines. And then last but not least, we have Dr. Dang, who will give us an update on all those immunization schedules that have been changed. And I will have a few minutes at the end to talk about School Champions, which is a big grant we got from the National Association of Nurses. I got a lot of emails from different states wondering what that was and what we did. So we'll have a few minutes to show you that. So with that, I'm going to move forward and just quickly let you know that our goal at ICLAC, we're a diverse organization and we're really grassroots, but a lot of it is just not LA County providers, it's other states that I share best practices with, hospitals, schools. We have a lot of churches. I think we have a list of about 400 faith-based organizations. And we have several hundred people who are on our email list for getting our newsletter, and they actually contribute to it. So thanks to the pharmaceutical people in the room and on the call who submitted all kinds of stuff to help others deal with immunization challenges. And basically, we're here to collaborate and really try to get the uptake and education out there about immunization. So that's what ICLAC does. And just a few things in the room and also those on the phone, you can go to our website, but we did a lot with schools this year because we couldn't get kids to get vaccinations. So instead of trying to make them get vaccinations, we made them get education about immunology. So we did a STEM program and we had what we call a Jeopardy. And the kids went off the cliff and they did get the vaccines after they did all this research with us on what bacteria looks like on doorknobs, on sneakers. So what we learned from that was we need to find a different approach to the schools, and we're doing that. So if you're interested in that, we're more than happy to share that it's online. Also, for those of you who are not in the room, there is a parent's guide to recommended and required vaccinations that I've had other states call me about, and Azita is the author of it. We have it in Spanish, English, and a lot of other languages. You can also go to the website and download a printable version. I have people out of the country who are downloading this because they like how simple and easy it is. But that's going to help us rise up and get more uptake in education. And the last two things you should be aware of, we did probably the largest event we did. 10,000 people showed up. It was not our event. So what we learned was we need to partner with organizations that can bring people. That's all those umbrellas that you see, and get people to the table. So we partner outside of the state and the county. And last but not least, a couple of other things outside of our newsletter. If you go to the website, we do have downloadable presentations too. The biggest one, I think over 1,000 people downloaded, was what I called Faith for Vaccines. For Black History Month, we did all the legacies of Blacks that had been involved in vaccine development. And that thing is still going. People are still downloading and they're calling me to get more information. But in the room, we have church fans that we distributed. We distributed church bulletins to churches in addition to that presentation, which a lot of ministers showed as part of their sermon, believe it or not, during Black History Month. So with that, I will get out of the way and introduce you. You already, you'll get this slide deck afterwards, but you already met Dr. Carrie Hurley Kim and myself. So I'm going to turn it over to Jamie Vickery, who is the government affairs lead with Vaccinate Your Family. And for those of you who don't know, Vaccinate Your Family is one of the largest vaccine advocacy organizations. It was started by two first ladies, including Rosalind Carter, and it is huge, meaning half the organizations I collaborate with have some connection and some have been referred to me by Vaccinate Your Family. And they do a lot of education and support so we don't have to reinvent the wheel. So I will turn it over to Jamie and let me make sure she can share the screen. She's going to be in Zoom land with the Zoom land folks. So hold on a second. Okay, Jamie, can you share the screen now? Just put it in the text.
No, I can't.
Okay, hold on one second then. A little audio difficulty, of course. Jamie, are you able to share the screen yet?
All right, can you guys see the slides? Am I good?
Let me
Not
get out
yet.
of this.
Not yet. I don't see slides.
Okay, let me get out of this. and see if we can't close this slide up.
It says I'm loading.
Oh. Your slide deck is pretty large, that's why. So we'll just give you a moment to load your slides and then you should be able to share the screen. And thank you all for your patience. This hybrid thing is a little tough. So maybe someday it'll be either or not neither. So we won't have to do it this way, but. So Jamie, you just tell us when you're ready and you can have the screen.
Okay, and thanks for your patience. And it looks like it says you are screen sharing, so it looks like I should be good. If you can see the capital, we're good.
Not yet. Looks like it's still Tracy's screen. Yeah, the screen I have on still has some seashells. Still the seashells.
All right, it says I'm screen sharing, but I can go ahead and talk about a State of the Union and what it is, and then hopefully these slides will load up and you can get a much more detailed glimpse into our report. So I'm really excited to be with you all today, not just to talk about immunization in the State of the Union, or we call it the SOTI, State of the Union. It's meant to be a play off the President's State of the Union speech. But I'm actually born and raised in LA County. I was born in Long Beach, lived there for several years. So my family moved to Temecula, went to college in LA County, moved to the East Coast, and then ended up working for the congressman from Long Beach. So it's really good to be home. I feel like I'm with my people, West Coast, best coast. And I'm don't like to admit it, but I've lived in California or lived in DC longer than I lived in California, but I will always be a California girl more than I will ever be a Washingtonian. So thank you for having me. I was going to make a comment about missing the sunshine, but I think we had a much more mild winter out here in DC than you all did. You actually got snow in some parts of LA. We did not get any snow this year. So it's been a very weird winter for us. So if you do want to come out to DC and see the sun and the cherry blossoms, please come. You're more than welcome. So go ahead and talking about the State of the Union. So we call it the SOTI, short for State of the Union. And it is essentially our, let me back up and talk about Vaccinate Your Family for those of us who don't know who we are and what we do. So we were founded about 30 years ago by former First Lady Rosalind Carter and former First Lady of Arkansas, Betty Bumpers, Mrs. Carter and Mrs. Bumpers, when Mr. President Carter, then Governor Carter, was governor of Georgia. They met through the Spouses Network and just hit it off and really decided to work around this issue of childhood vaccinations. And from their incredible advocacy work, the Vaccines for Children program was born. And that is a program, I'm sure most of you are familiar with it, and it has been incredibly successful, that provides free vaccines to kids whose families don't have insurance or on Medicaid, or children who are Native. So it's been a really incredibly, tremendously successful program, and we stand on the shoulders of giants here at Vaccinate Your Family. Since then, our work has really expanded around increasing vaccine confidence, combating misinformation, combating hesitancy, providing good, solid, science-based, factual information. And we've always taken the philosophy around hesitancy and confidence that it is okay to ask questions. You should ask questions. You should ask your doctor, ask your medical provider, ask your, certainly ask your pediatrician, ask your OB. You should think about vaccines and you should know what you're doing. the evidence is out there that if people are open and honest, they will come to the right answer. We're not, it's okay to question. You should think about your health and your treatment plan with your doctor. So one of the things that we also work on is policies to increase vaccine access. And a lot of that, of course, has to do with so going through my slides. I can see them, I guess, even if you can't. The really great thing, I wanted to highlight some great news for you all, is that in the past 30 years, the Vaccines for Children program has been around for about 30 years. The incredible thing is that childhood vaccinations in that past 30 years have prevented 472 million illnesses, 29.8 million hospitalizations. And here's something that's really incredible and amazing, I think about every day. Childhood vaccinations in the past 30 years have saved 1 million lives, which is incredible. And if that's not an argument for increasing access to vaccines, I don't know what is. The State of the Union, like I said, we do it every year. It comes out. We try and time it around the State of the Union that the president gives every year. And it lays out our federal priority policies. It's essentially our wish list for Congress in what Congress can do to increase access to immunization for folks across the lifespan. We tend to think of vaccines as something for babies or for children or for older folks. You always think of immunize, make sure your mom or your nana gets hers, but we need them across the lifespan, not just when we're little or when we're older.
And Jamie, we can see your slides. We were able to see them after the second slide. Thank you.
Perfect, fantastic. This is, there's a lot here, so I'm glad you can see them instead of just hearing me speak. So there's 4 priorities within our State of the Union. And the first is ensuring access, ensuring everybody can get those vaccines. The second is strengthening the vaccine ecosystem. There's a lot of pieces, as you all know, that go into getting somebody vaccinated. It's not necessarily just the person going to the doctor, going to CVS to get that vaccine. And then maintaining fair compensation for people injured by vaccines. We know vaccine injuries are extraordinarily rare. They do happen. People need to know that, God forbid, something does go wrong, they can still be compensated for that injury. And then helping to reignite a culture of immunization. So we can walk through these 4 priorities. So the first is access for publicly insured adults. That's ensuring Medicaid and Medicare not just cover vaccines, but cover those without a copay. Certainly for people on Medicaid, things are already tight, and a copay could make the difference between getting that vaccine or not. California is great for many reasons, but one of the things that it's, in my world, California does cover all 14 recommended vaccines for adults under Medicaid. So this will be less of a transition for California than for some other states. But as of October 1st this year, all states must cover routinely recommended vaccines for adults in Medicaid with no copay. So you will not have any folks on Medicaid will not have that financial burden. That could really be an issue for some states that don't cover HPV. I looked this up, at least in the Washington, D.C. area. Getting an HPV shot at CVS Minute Clinic was $261 out of pocket, which is a lot of money. That's groceries for the month. That is half your rent, depending on where you are. So that's a huge burden that it will no longer be there. The other really great thing here is Medicare Part D vaccines are covered. Seniors no longer, if you have a Part D drug plan, you will no longer have a copay for any vaccine that person might need, which again is a huge issue in huge victory in increasing access. And that was done in the Inflation Reduction Act. It's kind of a misnomer of a name. There's a lot of other things in there that happened all at once. And that passed last year. Like I said, Medicare vaccines are free as of January, and coming in October, it will be for Medicaid. So it's fantastic. We are, I always joke whenever I get really excited, I go back to my California roots and say I'm super stoked about something. So I'm super stoked about this. This is another thing that we are working on is access for uninsured kids. And this graphic's pretty, it's pretty startling to see the difference of children who have private insurance and children who don't have insurance. And we really are failing these kids. These are our kids just like any other, and would deserve to have the best shot and deserve to be fully protected against vaccine preventable diseases, as well as the community issue here too. These are the same kids our kids play with at the playground, at the park. They're in school together. They're riding the school bus together. So it's kind of because it's not only the right thing to do, but it protects everybody as a whole. But this is a pretty staggering graphic and a pretty staggering statistic to look at, and really underscores the need to strengthen the Vaccines for Children program. It's pretty great. It's pretty amazing. Like everything else, it could be better in terms of access, in terms of more providing physicians. The other thing we are working on, so if you have private insurance under the Affordable Care Act, vaccines are covered, no copay, great, fantastic. If you have Medicare, you're covered as of the 1st of this year. If you have Medicaid, come October 1st, you'll be Medicaid, or you'll be covered for vaccines. If you don't have insurance, you're in a different boat. So this is a whole chunk of people that are still out there that we're still working to make sure have access and can get the vaccines that they need. When you look at this flu vaccination statistic, it's less than half of people compared to those with insurance. That 37% number for a flu shot is still pretty bad. We're working on that, but it's pretty radical difference you can see there. So there is a program called the Vaccines for Adults program. It builds off of the success of BFC. It's similar, it's structured very, very similarly. The president has proposed this in his budget request. The budget request really doesn't have any form of law. If you hear any talk about that, it's kind of a wish list that he sends up to Congress. Given the political makeup of Congress this year, this is pretty much DOA. It's not going to happen. But we are really working more to educate people about how many people really are insured, what uninsured people look like. They don't necessarily look like who some people would think they are. And really the need for everybody to have access to vaccines, regardless of your insurance status. You look at this, and there are, the last figures I saw, it was 27.4 million people in the country don't have health insurance. That's more than 8% of the population. And if you think of the fact that these people don't have access to vaccines and therefore probably are not getting them because they're not cheap out of pocket, what does that do in terms of community protection? What does that do in terms of herd immunity? And that includes 70,000 people in California. As good as some of our systems are, there's still this huge chunk of people out there that need this. So here's what we're asking Congress to do. These are our asks, our wish lists, which is ensuring some of this rollout of Medicaid. Medicare went incredibly smoothly. Knock on wood, we don't have any issues with Medicare as people are taking advantage of this. Medicaid, like I said, California is great. We're not worried at all about California. There's some other states that their state government, their governors have not always been vaccine friendly, that we are watching and working with people on the ground there to make that happen. So you can see our wish list there around increasing access. And so funding the vaccine ecosystem, you can see there's a number of pieces here. It's not just somebody going down to CVS and getting their flu shot. There's a bunch of things. You have to make sure people know where to get them. You have to make sure the vaccine is there. It is where it's supposed to be. And then you have the community groups in just reinforcing that message of you need this, it is safe, go get it, here's where you can get it, etc. So there's a lot of text on the screen, but you can see. So one of our biggest priority probably is something called the Section 317 program at CDC. And the Section 317 program makes grants out to the states. And and state and local health departments. And then they can use those for any sort of immunization related activities. They can use them to staff a clinic. They can use them to take a van out to Walmart on a Saturday morning, to the soccer fields, wherever people are, that they can get them vaccinated. It's chronically underfunded. No surprise there. Public health, we kind of operate on a dime. We know how to pinch a penny until it screams. And we just have never been fully funded at that. Last year in the appropriations bill, we got 680 million. It has increased a little bit over the past few years. It's still not nearly enough to meet all of these needs. So you can look and see at this. We went and looked at some of the big public health outbreaks issues over the past few years and how much that costs to respond to. And you can see it's just not nearly enough money. If you remember the Hep A outbreak, we put San Diego in here, but obviously LA County, San Diego and LA County are so closely tied. You can see how much money it was 12.5 million just in one county alone to address that. And you can see some of the measles outbreaks of the past few years and how much that costs. And you can see it's just not nearly enough. So our ask here for Congress is to fully fund the Section 317 program at 1.13 billion. That is the number that sort of public health experts have, and administration officials have agreed on to, is the number they need. The president's budget request, which again is not a, doesn't have any force of law, but is kind of a marker, came out at 998 million. So we will see. The politics this year are really tricky and ugly, to be honest. So we'll see what happens, but certainly this is something that we are working on. We want to make sure you have adequate funding to do the amazing work that you're doing on the ground. The other thing here is a specific line item in IHS for immunization funding. I know Southern California, you all work with there's a lot of tribal nations working with those communities. There is no specific immunization line in IHS for that kind of funding. And it's a little less in the tribes in California, in Southern California. But if you do out on some of the reservations in the Dakotas or in Arizona, Native folks do really have some pretty terrible health disparities and some comorbidities. And more than anyone else, those communities need vaccinations, given some of the other health outcomes that are happening there. Immunization information systems, there are the immunization state registries, and all of these. We found in COVID that it is really hard for these systems to share information, either amongst themselves or outside of it to other systems. Less of an issue for you all, but where I live in DC, I live probably about 4 miles from the Maryland border and about 4 miles from the Virginia border. So as you can imagine, people go back and forth all the time. There are a lot of issues of somebody lived in DC, they work in Maryland, they got their COVID shot where they work in Maryland. The DC and Maryland systems couldn't talk to each other. And then we have our little immunization cards. If you lose your card, there's got to be a way to be able to go and replace that easily. Doctors' offices and public health officials can pull up that information as well to know what you had. My mom still has my little yellow card from Long Beach Unified School District. Not everybody has kept their card. Those are easy to lose, especially if you move around. So, finding a way to have those records electronically. We have all of our banking records electronically. We have everything else. There's no reason we can't do it for immunization data. And then the other thing that I wanted to highlight is student loan forgiveness for public health professionals. The appropriations bill, it was something called an omnibus. Usually there's 12 appropriations bills. They put a whole bunch in one this year or last year, just given some of the politics with the election, called an omnibus because it's all of the bills together. That included a provision that would provide up to $150,000 in student loan forgiveness for public health professionals who agree to work 3 years in a public health department, which is fantastic. It's already been passed. And so we're asking Congress to implement that quickly and make that happen. I don't have to tell you all that student loans can be a huge, huge issue for a lot of us. And, really if you come out with an MPH, you went to grad school, you can have a lot of debt. And we're really hoping that this is an incentive for folks to get good, bright, young, new talent and to keep that talent in public health. Certainly the past few years have been incredibly challenging, and people are retiring or people are going to the private sector, and it's not hard to see why. And so we're hoping that the student loan forgiveness piece is a way to help keep people in public health. Can't do any of this work without good people. So we want to make sure that good people are staying in public health. The other thing here is the third priority is fair compensation for vaccine injuries. So you can see there's only 2 reported injuries for every 1 million. And those are reported. May not necessarily be valid. And over half of those are something called SIRVA, which is shoulder injury related to vaccine administration. All right, got it. And that is not necessarily the vaccine, but how it is administered. So these vaccine injuries are extraordinarily rare. Unfortunately, they do happen. So there's something called the Vaccine Injury Compensation Program, VICP, and it is a separate system. It's designed to work much more quickly than going through a traditional court system and a traditional civil suit. Essentially, if you file and you have the medical records to prove it, and you have X injury caused by Y vaccine, you get this amount of money done and done. You don't have to go through the whole trial process. Unfortunately, VICP is it's heard by 8 special masters who are trained in this. They're experts in vaccine law and compensation and liability law. There's just not nearly enough people. The number of claims filed through VICP have just grown exponentially in the past few years. Some of this is because of how widespread flu and COVID shots have been. Some of this is kind of the anti-vax establishment trying to mess with the system. And some of this is increased hesitancy, increased skepticism. So it's really to ensure that these cases are heard quickly. We need more staff. We need more special masters. We need to be able to increase the amount of compensation just to keep up with the cost of living. So this is something, certainly especially if somebody had to get vaccinated for their work, they get hurt, they can't work, we need to make sure that they're taken care of. They're trying to do the right thing. We want to make sure people are not unfairly burdened by trying to do the right thing. The other thing here is COVID vaccines. Right now, they're in something very, very similar. It's called the Countermeasures Injury Compensation Program. So it's CICP. So a little bit of alphabet soup in DC here. And CICP is really designed for emergency measures to combat an emergency. So traditionally, these have been things like if people were exposed to a chemical spill and had to take something and then had problems from that, or equipment, et cetera, for sort of a one-time centralized, localized emergency. A great example of this, and I'll reveal my age, is that in 2001 or 2001, I can't remember, it's a blur. There was an issue I worked on Capitol Hill, there's an issue with anthrax in the mail. So a lot of us had to take a Cipro as a prophylactic measure to make sure that none of us had any injuries from the anthrax. Cipro did make a couple of people sick. So if they wanted to, they could have gone through the CICP. The problem with that, like I said, it's never been designed for something so widespread and universally administered as COVID vaccines. It does not have the manpower. It does not have the resources. And so vaccines are eligible for VICP once they are routinely recommended for children. COVID now is, and then Congress has to pass a tax on that, but we do need to begin the process of transitioning COVID into a program that is more adequately designed to handle these issues. And again, it goes back to the fact that people need to know that in the very, very, very rare case that something happens, God forbid, that they're going to be taken care of. They're not going to lose their livelihood for trying to do the right thing. And then the other one here, this is kind of less of a legislative ask and more kind of a culture shift and things that we are working on, is really engaging communities and engaging community-based organizations. We work very closely with the National Council of Negro Women and Dia de la Mujer Latina, supporting promotores, supporting community health workers, and really engaging people within to work within their own communities, knowing that people get vaccinated because it's normal, because it's just something everybody does, because people get vaccinated because, oh, even in the cases of your grandma told you, or, you know, in the case of my brother finally got a flu shot because my mom stayed on him and nagged him. You're never too old to have your mom nag you. And so we really engaging and working with these communities. We know that they work. We know that their vaccination efforts that were built up during COVID really are incredibly effective, because they are people within the community who are already well respected, who are already known within that culture. They know the culture, they know the neighborhoods, even getting down sometimes block by block, that they know these folks and they know what works and how to reach them. So the things that we are doing is we found some of the issues, because these community-based organizations are not your traditional groups. They're not necessarily something like the PTA. There are things coming out of churches, coming out of the Y, coming out of just community groups, that they may not always have all of the resources some of the bigger groups and bigger players do. So we wrote a report on this. The president did issue an executive order a couple of months ago around trying to address some of these barriers that these organizations face. They may not have a grant writer on staff because they're so small. They may not even have staff, full-time staff, and making it easier for them to participate and get access to these grants to do this incredible work that they're doing. And this too is kind of engaging social media. There's a lot of misinformation on social media. So how do we put good, real information out there? Show your support, link to science-based information. I always use the term shot fee. I'm determined to make shot fee happen. So share your shot fee. It's a selfie when you get your shot. I think it's funny. I don't think anybody else does. But to share things like that makes vaccination this cool, fun thing that people are doing to combat some of this misinformation and hesitancy that's out there. So we need your help. Of course, these are all things Congress reacts to what they hear in the community. Anti-vaxxers are, thankfully, they're not numerous, but they are loud, and they're getting better and better organized and more and better funded. So it's really imperative for all of us to, we know most Americans support vaccines. We know that vaccinating yourself and your family is the norm. We just need to make sure that Congress and our policymakers hear that. So you can sign up, you can certainly find our State of the Immune report, share it with your members of Congress, sign up for our immunization alerts. We have ways for you to reach out to your members of Congress about these issues. We have some forms that are already written for you. You just fill in your information, it'll pull up your member, sends it to them, easy peasy. You can do it standing in line at the grocery store. You can do it waiting to pick your kids up from school. Put your phone down once you drive, but it's super easy. We really encourage you to do that. We also have something called the Vaccination Collaborative. That has been our effort to engage sort of non-traditional partners, people who haven't necessarily been real engaged in advocacy in the immunization space. Things we're reaching out to other groups as well, things like childcare associations and daycares, and my dream member here is to get the Girl Scouts. We haven't gotten them yet, but to get some of these groups that whose work is really engaged and really involved by vaccination. They just haven't always had the resources or the know-how to be engaged in advocacy. So yeah, that's called our Vaccination Collaborative. We have monthly calls. I think it's every second Tuesday, but if that's something you're interested in joining, please email me. My name is spelled kind of weird, so I put it there for you. And then we do a policy call every month that is a little bit wonkier and nerdier than the vaccination collaborative. Those are for people who are already advocating, who are already in this. It's just kind of we started the vaccination collaborative just not to frighten people off by some of the really wonky technical stuff that we do on the policy call. You're certainly welcome on either one. Both would be great. So that's something you're interested in, please feel free to email me. So thank you so much. Thanks for letting me speak to the hometown crowd. And if anybody has any questions, I'm happy to answer them.
Thank you for that, Jamie. I think if we have any questions in the chat, Carrie, Dr. Kim is going to look to see. Other than that, I will tell you all, if you haven't joined the vaccine collaborative, even if you don't do policy, they promote events, activities. I find out about grant stuff, so it's really helpful, the traffic of all these organizations across the nation that are involved in vaccines. Even webinars and CMEs and all kinds of stuff come across. So I would encourage you just to do it just so you get more information. So with that, there's no other questions in the chat. And Jamie, I wanted to tell you, we do have a gift for you. And I'm gonna tell you what it is because you're in Zoom land. So we have this t-shirt that basically has all the different vaccinations, and it spells out vaccinated on it. So all the speakers today would get this shirt, and there's a candle that goes with this for stress. So we're gonna give you this special shirt that I'll share with you, and I'll try to take a picture, Jamie. So just email me your address so we can get you your speakers. This is in lieu of an honorarium. So thank you a lot, Jamie, and we'll give you a round of applause. And those on the phone can do the same. So I'll
Great.
stop sharing the screen. Thanks so much, Jamie.
All
I
right,
know how
thank
busy
you,
you are.
everyone.
All righty. All right. So originally we were supposed to have a break. Jamie did really good time. So before I do that, thanks, Jamie. I wanted
you
to,
all.
thanks, Jamie. I wanted to acknowledge all the other folks out in Zoom land, a lot of people I know, and I wanted to tell you all, there's some listening, watching groups. In total, we have about 75 people on the call and almost 30 in the room. This is the highest attendance that the Immunization Coalition has ever had, according to Carrie Hurley Kim. She said the average used to be about 20, so we broke a record. So thanks to all the great speakers and all of you who've gotten involved with the Immunization Coalition. We're up from about 20 organizations to about 50 members now, so thank you very much. So with that, I will ask everybody on the call to stand up and take a stretch break, because they say sitting is the new smoking. So I want people in the room to take a stretch break. Stand up, put your hands in the air. Yes, it looks silly, all of you on the call. I don't want you to say I was detrimental to your health. And then we'll get to the next speaker. So thank you very much. Okay, so we're gonna take a 5-minute break and then we're gonna rejoin and go ahead and go to the next speaker. So instead of the break at 10:15, we're gonna take 5 minutes now. And please be back in the room at 10 o'clock exactly our time, which on the East Coast is 1 o'clock, okay? Thank you. Oh, yeah. We give.
The weather is actually warm. Like this is just, I know it's cold. I guess around here, but it's beautiful. Yeah, well, yesterday I woke up.
Oh, okay. Yeah, I get a little snow.
Perfect. Yeah. I'm very perfect.
Oh, yeah. Yeah, it's actually cool. Water filtration, and then like on my
Very cool.
the nerd school.
Orchid friends. And they're really basketball team. Yeah, I'm like, you guys, you know you're upgrading, right?
Yeah. Very
Yeah.
Yeah.
Okay, we're going to get back started. So those in the room who are chatting will take a moment, grab your seat. Those in Zoom land, you can sit. So we're going to bring up our next speaker. I'm going to do her introduction first. Yep. All right, people are quiet. This is a good thing. Hey. Sorry, those in Zoom land. Mr. IT just killed my screen. We went dark, but he's rebooting it. So with that, I wanted to introduce you to our famed colleague from Johns Hopkins. So her common name to me is Alex, but I will let her speak earlier, but she's representing Johns Hopkins International Vaccine Access Center. So Alex, I'm gonna turn it over to you, and hopefully IT guy just ran away, so hopefully we won't have another glitch. But if we do, we'll just be patient. So Alex has been around a long time dealing with misinformation, and she does a great job of supporting how we deal with it. So we're gonna let her have the floor, and I'm gonna bring up her slide presentation, which is actually a lot of fun. So let me get it up on the screen for you. And I will turn it over to Alex. Okay?
Hi, thank you so much. Can you hear me okay?
Yes, we can hear you really well, Alex, and thanks for coming on today. Thank you.
Oh,
Go
thank
ahead.
you so much. All right, so for the slides, do I move them forward or does someone else move them forward?
I can be the someone else. I can be your navigator. You just tell me when.
All right, next, please. Or can I, let's see. Okay. Hi, everybody. So my name is Alex. I'm at the International Vaccine Access Center. And we have been doing a lot of work on vaccine misinformation. And this is not just an issue in the United States. This is a huge issue internationally as well. And so just to start off, we have a few different sort of approaches and tools for dealing with misinformation. And I'm gonna, in this talk, just quickly go over a few of the different tools that are out there. And I'm hoping that this will spur a little bit of conversation and that folks certainly invite you the last few minutes to share any experiences that you've had or anything that you've seen, because again, this has been a real challenge, not just for health, but for many other topics. And I think we're going to need some creative solutions to really try to get this under control. So I'll start off with just a quick true or false. What spreads more quickly on social media, misinformation or true information? All right, so take a minute to think. All right, next slide. Thank you. So this is a really interesting study that was published in Science in 2018. And they had a really interesting data set of real social media data. And they found that false information not only spreads more, but spreads very fast. So 6 times faster than the true stories. So this is part of the reason misinformation for vaccines has been such an issue, is it's really hard to get the true information out there at the same rate that the false information spreads. Next slide, please. Yes, so a theme of this talk is not using jargon and avoiding sort of traditional scientific methods of communication. So in summary, next slide, please. Thank you. And this is a really great report that the Surgeon General's office put out I think last year. And this is not just specific to vaccines, although vaccines were a big focus for this. I highly recommend checking this report out if this is something of interest to you. And again, just the scale and sort of the scope of like global policy groups that are interested in confronting health misinformation. It's everyone from the Surgeon General's office to the WHO. Again, just to give a sense of sort of the scale, and I'm sure you all like have your own experiences with this, but as social media becomes a much more globally used source of information, the number of people using and potentially being exposed to false information is enormous and growing all the time. So this data is from 2021, and so this is already out of date, but 4.2 billion social media users around the world. Facebook alone has 2 billion with a B users. So vaccine hesitancy can be kind of sparked by information people see on social media. And there's lots of different ways that this can occur. One thing that I found very interesting during the pandemic was looking at some of these Facebook groups. Some of them are open, some of them are closed. And even even general groups that have nothing to do with health information or vaccines, I was seeing people spreading false information about vaccines. And I thought this was really interesting. And I think this is a really common issue that I don't know that public health has been well prepared for how to deal with, because some of these Facebook groups have 40, 50,000 people involved, 100,000 people involved, and it's a real challenge. Thank you. And we have some of the challenges. So the scale is just enormous. There's no way we can debunk or respond to every piece of misinformation, even if they weren't circulating in some of these closed groups. Definitely, there have been accusations that major social media platforms have been very complacent or even amplified misinformation. They certainly, I think it's fair to say, have not done everything they could do to collaborate with public health researchers or professionals to help mitigate misinformation. And then the last challenge is that new misinformation is emerging all the time. So some of the other things that make misinformation really difficult cognitively is that misinformation is sticky. So even when you've heard something false and someone corrects it, even if you believe the correction, people will often retain that initial memory of the false thing they heard first. And so a challenge for us is people hear false information about vaccines, and even if they accept when you correct it and you give them true information, they may unintentionally kind of keep that false information in the back of their mind, and it's really difficult to sort of overcome that stickiness. The other challenge for us is backfire effects. So if you attempt to correct misinformation, that can sometimes make people dig in even deeper in their belief in the false information. And so there's no simple way to just fix when people are exposed to false information. This is one of my absolute favorite illustrations of the information deficit model, again, using a simplified version to kind of explain a long-winded sort of concept. But essentially, I think we've all had this experience of having kind of a traditional background in, like, if you give people true information, they'll just go along with what you say, but we all know anecdotally that it's not that easy. And I love this illustration for many different sort of experiences with trying to mitigate false information beyond vaccines. And so this is a really, really great resource. This was published, it was published pre-pandemic, I want to say around 2018, by the National Academies of Science. It's basically sort of a compendium of science communication research. And the executive summary is great if you don't have time to read the full, it's essentially a book. If you don't have time to read the full report, it's fantastic. And so one of the great flaws in scientific communication generally is this model that we assume that people believe what they believe because they don't have enough information. And we sort of forget or don't follow our own advice, and that the research shows that is just not true. So this information deficit model of if we just give people the true information, the problem is solved, is not scientifically validated. And so I think we have to think more creatively about ways that we can communicate with people that are not reliant on this information deficit model. This is a tweet I came across that, again, I feel like summarized this report in about 20 words. So again, if you do not have time to read the full report, this tweet kind of has you covered. And for folks who maybe are listening in the background, it says, "I still think my favorite thing that's ever happened to me on the internet is the time a guy said, people change their minds when you show them facts. And I said, actually, studies show that's not true, and linked to 2 sources. And he said, yeah, well, I still think it works." This is, again, like a topic that Dr. Peter Hotez, I think he's at Baylor University, huge online advocate for immunization, has addressed actually quite a lot. And this is a quote from him from pre-pandemic, is that we live as scientists in a cone of silence culture. We are not trained with how to communicate outside of our field. We are in fact sort of trained to be a little antagonistic towards communicating outside of our field. And that's something that, I encounter quite a bit as someone who has sort of a traditional communications background more than a research background. And again, a tweet that just sort of summarizes, for a lay person trying to read any kind of like scientific publication is often like very, very, very difficult and unpleasant, even if people want to know what we have to say. So this is a really exciting project that one of our teams at Johns Hopkins has been working on. So this is a chat project called Vera. And if you happen to be on the chat, please feel free to put in the chat if you've ever used this or have any experience with this. And so this is a chatbot that we designed with a team at IBM. And in 2021, they approached us and were like, we would be really interested in using our AI to work with you on coming up with a resource to help people sort of debunk false information about COVID-19 vaccines. And so essentially it's a chatbot that was designed to be anonymous, accessible, comprehensible, and to also give us sort of this bonus of a little bit of social listening, of figuring out like, what are the questions that people have now, because people's questions can change over time. And so here's an example of a chat I did with the chatbot. And so how it works, and also I want to say it's really exciting because it can be customized. So customization is item 4 on this list here for different groups and organizations. And so essentially what we did, this does not work in the way that things like ChatGPT works. It's not generating text probabilistically. We write the responses and the AI sort of figures out what someone's asking and chooses the right response. That way we make sure that people are getting credible responses that have actually been reviewed by public health folks. So the chatbot is not making up the response. We write the responses. It is interpreting the question. And so here's a question that I asked, and I want you to pay attention to the way the chatbot answers. So it includes emojis, and it includes a really sort of human tone, almost like you're talking to a friend. So one of the advantages to this, and there's been some research on chatbots in other areas of public health as well. So Planned Parenthood has a really interesting chatbot, is that people are very sensitive to shame or feeling dumb or just not really having anyone they can ask some of these questions. And so, you know, often sort of the go-to response can be, well, talk to your doctor, ask your health provider. But a lot of people don't have that. And they turn to other resources. So if we make a credible resource easy and accessible, and think about sort of how it feels to be a little afraid and want to really know the answer, this is sort of one of our solutions. And so far, I think just in LA County's version of the chatbot, the latest numbers I've seen is there have been about 10,000 interactions. It is also available in Spanish, and it can also be used over WhatsApp. And so you can also customize it. And that's not just like the colors and things like that. We've been interested in some of the different ways you can kind of make it work with the population. Oh, sorry. Yeah, the sample chat is right on the left. So I asked it, I've heard that the shots don't work well. And the chatbot responds, the vaccine and booster shots are super effective. They help keep our community and loved ones safe. Hope that makes sense. And so again, like we spent a lot of time doing qualitative and quantitative research to get the tone right. And so the tone, the goal is that it's conversational. It's not speaking, it's not talking down to you, and it's not talking to you like a health provider, like an expert. It's talking to you like a friend. And another use of these chatbots, because again, during the COVID-19 pandemic, a real challenge for community health workers and other providers was keeping up with all of the different responses to the questions, because it was such a rapidly changing environment. And so in Baltimore, the chatbot team collaborated with a community health worker vaccine ambassador project to help make sure that our team going out into communities and acting as vaccine ambassadors had something that they could refer to. So they didn't have to remember, you know, 200 to 300 different sort of facts that were changing week to week as new things emerged. So they had something to go to and something they could refer people to as well. So not only can people access this like on their phone or computer, like for example, maybe you're waiting for the bus and you think of a question and you can look it up on your phone. Also, if you are working with a community health worker and you have a question, they can refer to this to make sure they're giving you the most up-to-date information. Or maybe it's a question they haven't experienced before. And so the most important thing I really, really want to emphasize with this is empathy is so important. Like you just cannot really address people's doubts or concerns if you are not speaking to them in a respectful and empathetic way. And so one of the things we've been really interested about with the chatbot is, you know, trust. Can we build trust by showing empathy and really trying to promote an open back and forth communication? So this is a paper that we published last year based on some of our mixed methods research on this. And we had some different groups of young people. The chatbot really is sort of tailored for a younger audience. And they wanted the truth. They wanted to feel like, you know, to build trust, you were talking to them and giving them the truth. And they really wanted to have a conversation. So I think that this is where some of the IBM team was really helpful, as the natural language processing engineers really do have a lot of experience with like, well, what are some of the ways you structure language to show empathy? And so these are some quotes from some of our qualitative research. I will just say we did experiment with some humorous responses. They did not go well. So we adapted some responses from social media that had received, you know, really big social media support. Did not work in this context. And so feedback was fairly consistent. Is to establish credibility, you need to use simple, direct language and kind of have again, the mindset of a conversation. People did not like when we framed it as a doctor at Harvard said, and then provided the fact. So people did not want to hear from health providers necessarily, and certainly not from health providers who were seen as elitist or sort of authority figures. And this is just a slide for the IBM team. One challenge we had is Project Debater, which is the IBM team that did the AI with us, is they do chatbots that debate, and they were very confused when we were saying, no, you cannot change people's minds about vaccines by debating them. That is just not going to work for this. So we actually had quite a lot of conversations about this. And so this is a study that they did that was on the cover of Nature last year, if you want to read more about them. And so again, really cool thing about the chatbots is you get this information of, and it's totally anonymous. We have no personally identifiable information of any kind, but you can see the trends in what information is spiking. And on the right side of this slide, this is a sketch from the WHO's infodemic research. And I thought they had some really interesting things that you can look for in some of this data. So you can see, and again, it's great that you may have access to working with someone who has some experience with analyzing language data, which we did not have a lot of experience with, but we have a collaborator who does. So you can look for words that signify emotion. You can look for different narratives. You can look for how quickly different trends are emerging. It's actually very helpful for us in sort of our health promotion efforts. And this is, I will go through these slides really quickly. This is just another methodology. So rather than trying to address misinformation after people are exposed, there's this emerging field of pre-bunking. And it's essentially debunking before people see the false information. And so this is based on inoculation theory, which is very robustly sort of used in lots of different areas of public health. And so if you go maybe 2 slides, yeah, so one more. Thank you. So here's some games that you can play, and this addresses some of the issues of scalability. Is people do like playing these games. They're very short. They're about 5 minutes. They've been tested in many different countries, and essentially they teach people how to identify false information. And then after seeing, how false information is used to kind of trick people, people become better at spotting misinformation generally. And so they did a version of this game with WHO specifically for COVID-19 misinformation. This game is also available in Spanish as well as several other languages. And this is just a study finding to kind of demonstrate how the game actually does seem to work, even with some longitudinal testing. This is a game called Cranky Uncle that is being developed for different countries at the moment. So it's developed by an Australian social psychologist. This is a very fun game. And so it's essentially, you're trying to discuss false information with a cranky uncle. And this game focuses on climate change misinformation, but again, it has sort of an umbrella benefit. So people learn these skills in this setting, but the skills are applicable to other domains. So you can also use these for vaccine hesitancy, and they're actually working on developing a module for vaccine hesitancy. So this game is actually very fun. And then this is my last sort of slide is a couple of projects we've done to help train community members to be vaccine ambassadors. And again, really relying on trust from people people outside of the academy, outside of research, outside of public health. And so this was a Coursera course that my boss, Dr. LeMay, developed. I helped with. It's been very successful to date. It's been up for just over a year. 30,000 people have taken the course. And this is my final slide, just a note to end on from the Steakums Twitter account. So I don't know, Tracy, if we have time for any questions, but
Yes, you have time, Alex.
okay,
If there
great.
are any questions?
Yeah, if anyone has questions, then please feel free, if you're on Zoom, to put any questions or comments in the chat.
Alex, the only thing I will ask you to do is to let the participants know how many different organizations or some kind of scope on the testing you're doing with the Vira chat box, what kind of
Oh.
organizations you're working with, and any morsels you've been able to glean from it.
Yeah, absolutely. So we've been working with NACCHO, and I think to date,
Oh,
I
you
think-
use the acronym a lot of people don't know.
oh, sorry. Let me see if I can remember the acronym. National Association.
Go ahead.
Oh, is it Association of County Health?
Getting close.
Oh,
National Association of County Health Organizations, is that it?
that's it. Thank you so
Mhm.
much. And
It's
so,
lit-
yes,
Yeah.
yes. And so there's sort of the original version of the chatbot, and then also several different municipal health departments have been using their own customized version of the chatbot. So you can embed it on your website. So I think it's Louisiana Department of Health has a version. I think the Boston Department of Health has a version. And I can definitely, let me look up and include a link so that folks can look up more information about this. And so one thing I think is really, really interesting and helpful too is that the English version and the Spanish version, we do see slightly different questions. And so this has been really helpful for us in seeing, you know, what kind of outreach activities and what kind of concerns are impacting different populations. So one challenge for us is because we are not collecting personally identifiable information, is we can make some assumptions about, you know, who we think is using the chatbot, but we don't necessarily like know, is it our target demographic, you know, younger people? We think so, but at least with the differences in language, we really can see some differences and concerns. And so in the Spanish version of the chatbot, the latest data I saw from last week, there are far more concerns about fertility from the vaccines than we see in the English questions. And so that can be really helpful for us in thinking about how we might want to, what organizations we might want to reach out to, and what sort of channels we might want to reach out to help address some of these questions. And so anyone have any
Let me let Carrie check the chat box to make sure.
I'd
So
like to ask a question if possible.
Go ahead.
Yeah.
I
Just say your
apologize.
name and where you're from so she knows.
This is Pavle. I'm with the Vaccine Preventable Disease Control Program. Just a quick question. It was rather lengthy and I didn't feel like writing it. So I was just wondering whether it's been considered, whether it's been looked at the very fact. So we know already, and we've known this for quite a long time, that the human mind responds to negative information or negative things in quite a different way than it responds to positive things. And so if you take a look, the anti-vaccine groups, they specifically go after the faultiness of vaccines. They specifically go after the negative things of vaccines. They never say, this is why not vaccinating is good for you. While we, public health, and this is not only us in LA County, but in general, we always go after the benefits of vaccine, vaccinating. So I just wanted to see whether something like this has been considered as a potential message, because it's something that we've known so well and we understand it very well as to how the brain works with such information. Thank you.
This is a great question. This actually comes up a lot and it's difficult to answer because different people behave differently and respond differently in different contexts. And so I've done some work. There's a really great group out of Washington, DC, that's DC Grandparents Against COVID, and they meet on Zoom regularly. And it's essentially, you know, kind of providing grandparents with the tools to talk to their families and their communities. And that came up is they were like, I don't really like all this empathy stuff. Sometimes you just need tough love and you need to like tell people like no. And it was interesting hearing that perspective. So they felt fairly strongly that there should be, and I think you alluded to this a little bit, but like, you know, they felt in some context this empathy thing just doesn't make sense and it doesn't work. And so I think that in the context of an interpersonal relationship, they had a really good point. You know, it's different than when you're trying to communicate with a stranger. And I think, so one thing I did work on recently, and our paper was published last year, is we did a multi-country survey doing some testing on COVID-19 messaging. And we found overwhelmingly, like you're saying, people were the most sensitive to kind of the scarier message. They strongly preferred it. And this was Ukraine, India, Indonesia, Nigeria, and the Philippines. So very different places, very different contexts. And so it was interesting to see, like, again, like you're saying, there was a strong sensitivity to the messaging that like the disease outcomes oriented messaging around COVID-19 and how it will affect your health, as opposed to say economic impacts or a social norms message of that like, well, everyone else is getting it. And so I think one thing that I would like to see more of is being able to refine, and I think social media is actually a really great way to do this, is refining messaging based on smaller populations so that we can use that kind of messaging like that you were saying that may be much more, I don't want to say negative, but kind of using a more negative tone with populations where we find that is like what matters to them. And I think that addressing people's real concerns and real, you know, fears is really important for us to do. I do think it can be not just a scaremongering, but, you know, a way of showing empathy by acknowledging that like people have very real concerns.
Yeah, thank you for that. Any other questions before there's some questions in the chat. So Carrie's going to note the questions in the chat for you, Alex, right now.
Oh,
It's
thank
on.
you.
Can you hear me?
So,
Can you go ahead?
okay, so I see a question about classifying negative information as not only misinformation, but disinformation as well. Yes, this is a very, very important distinction. So misinformation is often described as people don't have any negative intent. It's sort of like, you know, the cranky uncle example of someone is sharing things that are not true, but they believe those things to be true. They don't think they're false. Disinformation, on the other hand, is when it's intentional. The person sharing it knows it's false and is sharing it with a purpose. And so that is much more of some of these anti-vaccine groups because, you know, and I wish I could do a better job of trying to communicate. And we've been working on this a little bit, that they're not sharing this information because they care about you. They're sharing this disinformation because they're trying to sell products. They're trying to make a buck off of you. And I understand that there's some sensitivity with how to address that, and you can't just necessarily say that directly. But I think it's a really important distinction. And I think it's a much harder thing to go after the disinformation folks because, you know, they're often very organized, they're often very sophisticated, and they often are quite well funded too. So I think that's like, if anyone has any thoughts on that, that's something that, you know, I think is really important to really think about. And I see a lot less discussion generally about disinformation, where it's an intentional, strategic use of false information to accomplish a goal. Actually, you know, we have been trying to collaborate on this a little bit more with some of the political science folks. Again, this is a topic that kind of spans different areas, and I think they have a lot more experience dealing with disinformation. So one thing I would like to do in the future is to really, if anyone knows any political scientists who might be interested, please feel free to put them in touch. Is working with some folks outside of public health on this.
And then Alex, there was just one other question, can folks ask about any of the vaccines on here, or is it vaccines in general, just COVID vaccines?
Oh, this
So
is
they-
a really good question. So what we've been seeing, not only, so it's really interesting because the misinformation and disinformation go back and forth globally. They circulate. And so things might start in the US and then they go abroad and then they come back again. And so this is one where we are now seeing a lot more issues with hesitancy around routine immunization. And I think, again, like there's been some spillover from COVID-19 vaccines and hesitancy around those vaccines into sort of vaccines more generally. And again, a lot of these techniques and tools, especially the ones that involve some of the pre-bunking and the spotting misinformation, are great tools because they're not specific. So those tools can be used for any kind of misinformation. They can be used for routine immunization. They can be used for climate change misinformation, for anything. And so, yeah, it's definitely a real challenge. And again, we see this same trend outside of the United States as well. So it's a big global issue.
So Alex, can you update as to whether via a chat box that you already created will be able to answer questions about other vaccines?
Yes. So one of the things that's really cool about the chatbot is that you can update it. Like it can be updated, and we worked a lot on, I spent some nights where, there's some news that comes out from the FDA, a new approval or new populations eligible for the vaccine, and we're out there. And one of the things too that we have done in initial testing of the chatbot is putting a few different variations of responses so that we can kind of see which one is doing better. And so you absolutely can adjust it. So, one thing I think might be interesting is not just, routine immunization. HPV vaccines are another one with a lot of misinformation and some stigma attached. And so again, I think for a lot of folks, this makes it really easy for them. So one of the things I think would be really cool to test is to put some stickers with a QR code and a description of the chatbot around. So bus stops, just public places where people might be kind of standing and have their phones out. And one of the things, when you may not remember this from the slide with the chatbot, but it has a series of questions listed ahead of time. So you don't have to come up with your own question. So even if you're just curious, you can choose which questions go at the top, and those can match kind of what questions or misinformation are of greatest concern to you at the time. So if you wanted to, you could generate responses regarding routine immunization or tweak responses to focus on routine immunization as well as COVID. A challenge with that, though, is the responses have to be short. And so I have never had as much trouble writing as trying to write these like 10-word, 15-word responses. It is very, very hard.
Thank you.
Yeah.
Yeah, that's very helpful. So let's give Alex a round of applause, and those in Zoom land. So thanks, Alex. So email me your address so I can send you your in lieu of honorarium fund gift package, okay?
Absolutely.
And
Thank you so much, everybody. And I'll
Mhm.
put my email in the chat. Please feel free to reach out if you're interested or have any follow-up questions.
Yeah, and thanks to the Johns Hopkins team for choosing the Immunization Coalition to put the chat box on. It helps us build traffic because we totally relaunched the website and we get a lot of traffic now, comparatively speaking. So thanks for allowing us to be one of the places you chose to support. Thank you. Okay, Dr. Dang is up next. While he comes to the podium, I'll put his background up here because it's quite impressive. And while he's coming up, you guys can take your small stretch break. You can't talk, you can't leave the room. The principal's here. So I'm honored to just be in the midst of Dr. Dang because during COVID vaccine pandemic, he was out in the field and I'd run into his team out at places like swap meets. And I'd never seen somebody so polished and professional at swap meets and corner places that you don't see, even in places like Compton, which we had one of the largest turnouts ever of males. So there's something to be said for having other people that look like Richard that don't look like me. So I'll turn it over to Richard, and his bio is up there, but he's the president of the California Pharmacy Association, in addition to supporting the Immunization Coalition by being a vice chair, and he's the PharmD du jour in cooperation with Carrie, who's the other PharmD du jour that we go to for everything in the kitchen sink. So I'll turn it over.
Thank you, Tracy. Hi, everybody. It's great to join you again for the spring forum, and thank you for joining us. So as we wait for the slides to come up, Tracy had asked me to present today to talk a little bit about routine vaccinations. The CDC has a new initiative that we theme today's meeting against called Let's Rise. So that stands for the routine immunizations on schedule for everyone. So focus today is really just high level kind of overview of some maybe major vaccine updates to kind of be aware of, with a focus on the annual immunization schedule, and also providing you with the tools and resources that you might need as clinicians, public health experts, or advocacy groups or patient groups to provide and share this information to your communities. So just for some disclosure, as Tracy mentioned, I am the president of CPHA and the vice chair of ICLAC, and I also previously served on an advisory board with GSK. So I'd like to start by talking about the 3 R's of vaccines. So some of you may be familiar with this, but as we teach our students and clinicians about vaccinations, one of the core concepts is looking at the 3 R's, which is routine, recommended, and required. And that's how we kind of classify the types of vaccines that people might need. The vast majority of vaccine needs fall under the routine umbrella. And what does it mean to be a routine vaccine? It basically means that everybody should get that vaccine. That means everyone of a certain age group, of a certain medical condition should be receiving that vaccine. And it's something that everyone needs as they progress throughout life. Recommended might be vaccines that are needed for special situations, maybe due to your employment or due to a temporary condition or a medical condition. Required would be, you have no choice. And as we experienced through COVID, there was a COVID vaccine requirement that has been lifted now in certain places, but also some other vaccines that are required internationally are yellow fever for travel to certain countries, and as well as polio virus vaccine for certain countries as well. But beyond those 3 vaccines, there aren't really other required vaccines. There might be requirements for school, there might be requirements for employment, and so those are for smaller subsets of different communities. But today we're going to focus on routine vaccines, which again are vaccines that are needed and necessary for basically everybody and the general population. As many of us are familiar with, the vaccination levels and coverage rates that we've seen since the pandemic has taken a pretty big hit. So a lot of the misinformation and concern about COVID vaccines has bled over into all of our other vaccines that we have. And so part of the CDC campaign is recognizing that over the last few years, we've really taken a big hit in our vaccine coverage rates. We are seeing some slow rebounds, so there's some promising hope. However, we still see a backlog on the coverage rates that we need to have to fully protect everyone from vaccine preventable diseases. So just kind of summarizing some of the slides here is when they looked at the data of how many vaccines were being ordered from the Vaccine for Children program, there was a pretty significant dip. about 14 to 20% drop in the number of orders since the pandemic. There has been a slow rebound, again, with some promising hope. However, there are still certain subsets that have pretty large lagging disparities. So children, especially in rural communities, haven't seen a rebound. Children from low economic status haven't seen a rebound. And so there's still a lot of work to be done in those particular communities. Additionally, looking at students and children who are entering kindergarten, there's a pretty significant gap there as well. So you can kind of see from here that at least 250,000 children who are entering kindergarten are still missing one or more vaccines that are considered routine for that particular age. And that still represents a 4 to 5% drop from pre-pandemic levels. We see similar rates with adolescents for vaccines like TD and meningococcal. So again, we are approaching pre-pandemic levels. However, we're still below the rates that we need to be at. This trend is not unique to just children and adolescents, it's also for adults. And in fact, even pre-pandemic, adults were one of the most difficult groups to get optimal vaccine coverage rates on. But currently, based on the data that the CDC has released, we know that a majority of US vaccines are missing their routine vaccinations. 3 out of 4 adults are missing at least one or more routine vaccines. That's a pretty significant amount of individuals who are walking around unprotected from vaccine preventable diseases. So we can have a really big impact by educating, recommending, and administering all of these different types of vaccines. So a little bit of good news, bad news when it comes to recommendations. Good news is that this year in 2023, there's not a lot of significant changes. So, well, I guess that was the good news. The bad news is there's not a lot to talk about today, right? If you recall, last year I presented the 2022 updates. There were some pretty major changes made to the immunization schedule. This year, not so much, and we'll cover what the recommendations are. But I think that's great because that gives us a little bit of wiggle room to get used to new recommendations and to actually integrate and incorporate them. So the CDC releases an annual immunization schedule that is published and updated every year, every February of every calendar year. In their schedule or their recommendations, there are 2 types of schedules to look at. One for children and adolescents, one for adults. The routine vaccines are based on age groups and medical conditions. And then the contents of the immunization schedule is that it includes a cover page, it includes the schedule, it includes catch-up recommendations, footnotes, and contraindications and precautions. And I know many of those who are used to looking at the schedules are familiar with this, but we also might have some patients and community groups in today's session who may be hearing or seeing this for the first time. So this is really the gold standard recommendation where we look to see what types of vaccines individuals should be getting as they're being recommended by the CDC. The CDC can make periodic updates throughout the year. However, the major updates are usually incorporated into this annual schedule. And so like I mentioned last year in 2022, with that schedule, there were pretty major shifts in some of our different routine vaccines. This year, we've had some pretty minor changes, and that's good because that will give us some time to integrate. Anytime we have changes in recommendations and evidence, we know about the inertia that it takes to incorporate and integrate those changes. So it takes time to get the message out and to get people to accept and to get people to implement it into their clinical practice. So what's new this year in 2023? So in the children and adolescent schedule, they added the recommendations for routine vaccination for COVID-19, as well as a new MMR vaccine, Priorix, and then incorporated the new pneumococcal vaccine, PCV15. There's also new abbreviations for the COVID-19 vaccines for monovalent or bivalent. So you'll see it abbreviated as 1V or 2V, as well as for the platform in which the vaccine is created, whether it's mRNA or the acellular protein subunit vaccine. There's also additional clarifications in the recommendations for COVID, dengue, hepatitis B, influenza, MMR, meningococcal, quadrivalent, MenB, pneumococcal, and poliovirus vaccines. For adults, very similar updates. Added COVID-19, added the recommendation for pre-Hevbrio, which is a new hepatitis B vaccine we discussed, and then also incorporate that new MMR vaccine, Priorix. Similar new abbreviations for COVID, There was a new approving partner for the American Pharmacists Association. So from a pharmacist side, really glad to see them at the table working with the CDC on this. And then added clarifications for COVID-19, Hep B, influenza, MMR, meningococcal, pneumococcal, polio, and zoster. So those are kind of the high level updates of like what has changed so far compared to last year and this year. I'm not going to go into detail for each and every single vaccine, and I'm not going to go into detail of the entire schedule, but I do want to show you what the schedule looks like, and we'll just point out a few highlights that you should be aware of, especially for things that did change last year that we would like to see incorporated as we move into this upcoming year. Thank you. So first is the cover page that I mentioned. Cover page really just includes some basic information with abbreviations and links and resources. But the meat of the schedule is this one, table 1 of either the child or adolescent schedule or the adult schedule. So what we have displayed on this screen here is the child and adolescent schedule for routine vaccines based on age group. And the way you would utilize the table is that you would find the age groups in the column. So whatever age your patient or family member might be, you would find the appropriate column. And then you would go down the entire column looking at each row to see which vaccines are recommended. And the child and adolescent schedule is actually organized by the ones that are recommended for the youngest age all the way down to the oldest age. And for our purposes for routine vaccines, we're looking for the gold or yellow color. So any vaccine that is indicated in the gold or yellow color indicates that that is a routine vaccine. So as an example, if we have a 4-month-old child who we're trying to decide what vaccines they need, we would find the 4-month column and then just go down and identify which ones are yellow. So that we can see here that in the recommendations, we have the RSV vaccine, the DTaP vaccine, the Haemophilus vaccine, pneumococcal vaccine, and polio vaccine. So those would be the ones that are considered routine for children who are in that 4-month age group, right? The other colors are also recommended for certain conditions or certain catch-up groups, but for the purpose of routine vaccines, let's focus on the gold and yellow colors. So that's kind of how we would utilize the schedule. And this is really more intended for, a lot of the clinician utilization. As you can see, it can get a little bit complicated to use. And so later on in the presentation, I'll show you a more simplified version that the CDC has created, although I think that it can be even more simplified. And I just talked to Azita about that earlier this morning as well. In addition to that chart, you'll also see tables with more information. So this table is the catch-up schedule. So if your child or adolescent missed the age group where they needed to get a routine vaccine, these are the recommendations on how you can schedule follow-up doses to ensure that they are protected in time. There's a second table that organizes the recommendations by medical conditions. And so if you have a patient or an individual who has like diabetes or is immunocompromised or has other various conditions identified, these are additional recommended vaccines that should be given to those individuals. But at a baseline, we should always consider age when it comes to routine vaccinations. The next few slides contain a summary of the footnotes, and this is where all the detail lives. So the charts provide you with a high-level summary of what you need to look at from a visual representation, but the table really has all the details. And so for clinicians or for those who want to like read the details, it's all found in the footnotes. There's a lot of them, so we're not going to go over it. But I just want you to be aware that they are there, they exist, and that they are there. And you should I recommend that you definitely take a look at those if you are working in the vaccine space. The last item in the schedule is a table of contraindications or precautions. So it contains scenarios where maybe patients should not be receiving a vaccine because it might cause harm, maybe due to an allergy or another type of adverse reaction. So those are outlined in the final table as well. Now with the adult schedule, very similarly. So with the adult schedule, we see an age-based chart as well. It's a lot smaller, so there's less vaccines to consider, but similar concept in that we would look for those gold or yellow colored rows for the particular age group that you're looking at. Now, let's take a look at what we should focus on for routine vaccines. I mean, we all know about the annual influenza vaccine, but just summarizing what happened last year in case you weren't present or weren't aware. In 2022, there were some pretty major additions or updates to the vaccine schedule. One was that there was a change in the recommendation for hepatitis B vaccine. So as you look at this group for hepatitis B, we can see that there is a yellow color for ages 19 to about 6, I think it cuts off at 60. And so for those individuals, it is now a universal recommendation for routine vaccines. And that's a major change because prior to 2022, it was only recommended if you had a high risk condition. So moving forward, what we would like to see overall is more adults becoming vaccinated against hepatitis B because it is a routine vaccine that is now recommended for adults. Another significant change was the introduction of new pneumococcal vaccines. So there's new pneumococcal vaccines that have replaced the old ones that we have had, and it replaced new recommendations. So as you look at the pneumococcal column, here, you can see that there are 2 pathways for pneumococcal vaccines. There's PCV15, which is a 15 conjugate, combined with PPSV23, the 23 polysaccharide, or a single pathway with PCV20. And so those are the new pneumococcal vaccines that replace the previous recommendations. Additionally, we added the COVID vaccines to the routine schedule, and that includes the primary series along with the bivalent booster recommendations as well. Then hot off the presses as of this morning, the FDA has approved the plan to recommend a second bivalent booster for select adults if it's been at least 4 months since their last dose. Now, it does require CDC evaluation and CDC recommendation, so we're not quite there yet, but it looks like there may be a second bivalent booster for certain adults, primarily focusing on those who are age 65 and older and those who may be immunocompromised. So that is something that's coming in the pipeline to keep our eyes on. So with the adult schedule outlined very similarly, there's the age chart and the medical conditions chart. And then there's the footnotes with all the details that we definitely recommend to refer to. All right. So as we look at that, I always think that's pretty complicated, especially as we're trying to incorporate it in a busy, clinical practice or trying to get our patients and school groups and advocacy groups to utilize it. So the CDC does create a parent-friendly schedule. So on this chart here and the link that I provided, this is the current 2023 parent schedule that the CDC has created that they believe is more consumer-friendly. I don't think it's that friendly. I think it requires some updates. So I talked with Azita that maybe we can create our own in-house and work with you guys on that. And so at least this is what's available for right now. They try to make this, colorful and accessible for parents to be able to refer to. So those are some resources that you have on there. Additionally, for more resources, I think Tracy was handing it out, I saw her. We have some resources posted on our ICLAC website with the parent guide. It's available as a PDF. It's available in multiple languages, English, Spanish, and Chinese, simplified and traditional. So that's the booklet that was passed out. It does include last year's 2022 schedule. However, like I mentioned, there's no significant changes, so that's still very relevant for your use. And that one in your book, actually, I think is more patient-friendly. There's like cartoons, and it's just more accessible to the general population. Other resources to kind of be aware of is that the CDC does have an app. And so if you like having kind of information at your fingertips, that is something that you can utilize. It's available on iOS and the Android store. And it just kind of gives you the ability to look up the recommendations for different vaccines on the go. CDC also has different handouts and training modules and materials that you can use for your practice, as well as messages to share with patients who may be vaccine hesitant or who may need further information on the vaccines that they need. So those are kind of the main things that we wanted to kind of cover and make sure that we were all aware of. And I think that whenever we talk about the group with the summit as well, everyone always likes to know what's coming, right? So while 2023 updates were fairly mild, the 2024 updates looking ahead may be pretty significant again. So for those who are interested in the pipeline, there are a few vaccine candidates that are going to likely be approved and or get recommendations over the next few months and into the next calendar year. So just kind of keeping our radar open for those. So first is the RSV vaccine. And so you might have, if you were eagle-eyed, saw that it was incorporated into the 2023 children and adolescent schedule. However, the RSV vaccine doesn't have an ACIP full recommendation yet and is not introduced in the market. But we are expecting it over the next few months. And so the FDA has recommended approval for 2 RSV vaccines from GSK and Pfizer. And both of those, the different vaccines could be used in adult and children populations. So the RSV vaccine is likely something in addition that we're going to be seeing incorporated that can help with another kind of infectious disease alongside influenza and COVID. I can already anticipate that's going to be an uphill battle, trying to get individuals to accept another routine vaccine in that same kind of category. But it is important, especially as we see some pretty significant morbidity associated with those cases in the younger and older populations. Additionally, because I also practice travel medicine, so I get really excited about travel vaccines, there is a potential chikungunya vaccine that is also in the pipeline, which is a disease that's spread by mosquito bites in certain countries. And so that is likely coming up in 2023 into 2024. There is also a new dengue fever vaccine that is in the pipeline as well. So again, if you were eagle-eyed, you saw that dengue fever vaccine is incorporated into the 2023 children and adolescent schedule. However, with that one, that brand is Dengvaxia. That one is limited to children and adolescent of a certain age group who live in areas where dengue is prevalent and who've experienced dengue fever before. So very limited population. And in case you didn't know, the only places in the United States where dengue is prevalent are the US territories. So places like the Virgin Island and Guam, et cetera, for now. But the new dengue fever vaccine that's in the pipeline that's coming up is actually going to likely be approved for adults, so a larger age group population. And also it can be used for prevention. So you don't need to have dengue exposure before, unlike the current vaccine that's on the market. So that's also really exciting because then that's an additional vaccine that can be provided to travelers to prevent them from getting another mosquito-borne disease. Additionally, with meningococcal, that space has been changing a lot over the last few years with various brands coming on and off the market. In the pipeline, there is a pentavalent meningococcal vaccine that's coming out. So currently we have 2 meningococcal vaccines. One is quadrivalent because it covers against ACWY. That's the general routine one. Then there's a separate one that contains just the B, which is often recommended for adolescents who are entering college, for example. But there's going to be a new one that combines all 5 of them together to kind of, again, simplify that process. So while we can, the message is in 2023, without any major changes coming up, let's focus on increasing the coverage rates for our routine vaccines for both adults and children. And so that includes things like hepatitis B, pneumococcal, influenza, COVID-19, shingles, tetanus. So all those different groups, we should be able to be recommending those. Because when it comes to 2024, again, we're going to see some pretty new vaccines introduced on the market, which will then just, again, make it a little bit more complicated because now we have to talk to our patients about more vaccines and more vaccines But that should be sold with a message that, these are very preventative, they're very effective, they're very safe, and it's a great way to prevent these it's an easy way to prevent these diseases from occurring and impacting your communities. So with that, the big focus was making you aware of some of the changes in the schedule, making you aware of where the resources are, and just providing you with basic tools on how to utilize the schedule, as sometimes that chart can be a little bit confusing. So with that, we'll open it up to questions if there are any. Yes. Yes. Well, Puerto Rico is also one of the U.S. territories where dengue might be prevalent, so maybe that's where that chat comment came from as well. All right. Well, thank you. Pass it back to Tracy.
I know you all are excited because we're almost done, but I guess I'm last because Richard used to be last and I cut him short all the time. So I'm trying to be nice to him because he helped me out with a celebrity who's a pretty big name celebrity who needed a yellow fever vaccine. And she said, I'm calling you so I can get this today. And it was like 12 o'clock in the afternoon. And I was like, Richard, I don't want to alienate this celebrity because she might be of use to us later. And he's like, I got it, Tracy. And the next thing I know, he took care of her and she was flying out of the country to Africa for some big award. She had just won an Emmy and I can't disclose her name, but once I got that, I got another call from two others, but I was able to figure it out. So LA is an interesting place because celebrities think they can get vaccines on the fly. No appointment needed. So I appreciate Richard always figuring out how to navigate it without us getting on the news for not supporting things in public health. So thanks, Richard. So what I'm going to talk about is really how do you rise up when you have so many catch-up vaccines to do? And this special project that I got roped into with the National Association of Nurses, Azita sent me something across the desk and I was at a conference and I called them and said, your program is for the fall and we're already in October. And they're like, well, just get some vaccines done, in 30 days for these school kids. And, me, I'm like, yeah, sure, I'll do that. And who knew? So I'm going to talk about it because it's a funny thing that happened that ended up being a success despite all of the hurdles. So I'm going to bring this up because people need to know the challenges, not just the good stuff that happens and how you can navigate around it. And as you can tell from my accent, I'm from Atlanta, Georgia. I was born there, lived in California many years, but I grew up during one of the worst times in American history, 2 houses down from Dr. Martin Luther King. So no task is too daunting, right? And we got our health care from the fire station for everything from, because we were segregated. Black people went to a Black hospital, white people went to a white hospital. So I always think back to that and it really clouds how I look at the world and think everybody, particularly underserved communities, need to get this no matter what I have to do to get it to them. So that kind of colored my ambitions about this whole project. And I do a lot that way. So I get into something that I think I can't do and it gets done. So I'm going to bring this up about the Champions for School Health because these are school nurses that are across the nation. I did not know anything about the organization until this came across my desk. And we ended up with this great opportunity to try to do vaccines for underserved kids in like a 30-day time frame. Like I said, I was ambitious, thought we could get it done. And the learning that I had was, yeah, you can do it, but it might kill you. I'm still standing, but the success of this, they thought was so compelling because of everything we went through. So I'm going to go through a couple of things about the grant, some of the challenges, and then some of the outcomes, and then some of the analysis that's being done. As of this week, I think the National Association of Counties has asked me to speak about this because they were curious how some of these hard-hit areas we were able to get people who hadn't gotten their vaccines caught up. And then another organization, the CDC, has actually called. I know Andrew will be excited and asked to present at their Western Conference because the National Association of Nurses felt sad about. Yeah. Oh, you're going to help me. I'm trying to do two things and I can only do one. You're going to help me. Yeah. Do the presenters mode. Okay. This is what happens when you retire. Okay. It's coming up. There it is. Thank you. Okay. I'll go to that. Okay. So the first thing, 45 days, winter break was coming. And the focus was really, there are other crises that the school nurses had in LA County. A little bit different from other school nurses. Yeah, they're short staffed, but they had few things. We had this huge data hack that a whole nation and people in other countries knew about that stopped the nurses from being able to pull data and see who did or didn't have certain things. They had to go to the California Immunization Registry, but the database that the schools use is very comprehensive. It includes social determinants of health. It includes absentee attendance, all kinds of things that they need to know in order to get people vaccinated in context. The other thing we had is we had a fentanyl crisis. So the school nurses were told, stop everything, focus on educating and doing things about fentanyl. And this all happened right when we got this grant. The next thing that happened is the nurses were overwhelmed with kids with RSV, the respiratory virus. And then we still had COVID-19 in these underserved communities. So the funny thing was the nurses and I were just staring at each other going, how are we going to pull this off? And the scope and scale. Most people know LA County is the largest county in the United States. We have 10 million residents. Well, the schools are no joke either. Just one school district, LA Unified, has almost 600,000 kids. If we added the other surrounding school districts, we would be the largest school district in the nation. And I'm sure people just saw the strike that happened. So we've been having a lot of fun and still have the school nurses. So other districts, we decided we couldn't do everything for everybody. We ended up focusing on Los Angeles County Unified School District. The other thing is they said $30,000 or a little bit more than that. It sounded like a lot of money because, you know, I grew up without a lot and I thought that's a lot of money. We can do things with that. Found out it wasn't a lot of money. And then the weather. I'm sure you know, like in my yard, a 50-foot tree fell, stopped everybody from going to the Rose Bowl. So people were upset with me. But it was worse than that. We had all of the vaccine clinics outside. So if you can imagine, it's ice, snow, flooding in the underserved communities was really bad. And we're still trying to do vaccines, which, you know, it can be done. It was done. And then we had 2 mobile clinic partners. We only had 2. So the geography of LA County is pretty huge, but those 2 had memorandums of understanding where they could actually administer all vaccines. We had a lot of partners who were willing to do COVID and flu, but they needed to be able to administer all vaccines. So some of the strange things that happened was LAUSD was at their wits' end. So they were like, Tracy, let's do this thing. Originally, we said, let's look at the top 5 schools that have the worst case scenario, because we can only look good if we take the worst schools, right? If we improve them. So we started with 5. And then thank goodness to Susan. Susan, I didn't acknowledge you earlier. She's from Los Angeles County Office of Education. She was like, don't worry about it, Tracy. I'll get you into those big people's offices pretty quick. And she did. And so did one of the other doctors who was with the Immunization Coalition. Because I don't know if you know, but it takes a while to get appointments up the chain for a big school district. So the other thing that we learned about is when I said, you don't have to do a whole lot, I told the nurses, you don't have to do a whole lot. And they were like, sure, Tracy. And they believed me. But what happened was we had a lot of resources that they weren't aware of. There was an entire toolkit that had sample letters, text messaging, which unfortunately they had their phones taken from them, so they can't text parents anymore. But they did have letters and all kinds of other things like template flyers, messaging that you could put on a robocall in different languages. So that was very helpful. So once we figured out, okay, these are 5 schools, can we do the 5 schools? And it was like the 5 schools were having a really hard time because kids were not coming to school. There are a lot of people who didn't have checks and food and things like that. But we got through that part and we ended up with if you look at this, we looked at about 10 schools. And the reason for that is like this one middle school is adjacent to one of the other schools. And you vaccinate one kid in the family, there are other kids at that school. So we ended up doing a middle school or two. The other thing is about 90% of those underserved communities that were in the worst shape in terms of COVID and catch-up immunizations were Latinx and in the lowest quartile of income. And there were quite a few homeless people and homeless kids, and 30% were just learning English. So we kind of up against a whole lot of stuff. But at the end of the day, it's like, let's get creative. So here are some of the event samples. I actually created this flyer on the fly, literally. We found out the mobile clinic had the mobile van that was in this community had a capacity. And what was interesting to me was the principals and the nurses were concerned about, well, can you do incentives? So we did incentives, but we customized them to that community. The top 3 things that that community would like, and this was like a Christmas list. They wanted to be able to get a sandwich from Subway, an ice cream from Baskin Robbins, or a hot chocolate or something from Starbucks. So we did these 3 cards in very small increments. It wasn't like we did $50 or anything. We did like $5 and $10. And people lined up for this. We were just in shock, like, okay, they're coming. So the incentives are not the be all end all, but we made it fun. So I don't like to see kids waiting. So we had a kids corner, we had coloring, we had squeeze balls. I don't know if you can see these. These squeeze balls have inspirational quotes on them. So this is let your color shine. So we had crayon and different things from the California Department of Public Health that had activities that the kids could do while they were waiting. Meanwhile, we also did these other things to make it kind of fun. And these mobile vans do more than vaccines. So they were able to do other types of health assessments and do follow-up and triage some of these folks who hadn't been to the doctor or a provider in years since the pandemic. So it was a win-win for both us and the mobile participants. So here's an interesting one, and I know Azita came to help me, and we had a lot of people. That event that had 10,000 people, they were giving away free toys. But what they did was they had several universities, Charles Drew University of Medicine and Science did screenings. They had a reindeer and Santa Claus, but you couldn't go unless you had done the screenings, and you had to go to every table like ours. So we did a hand washing demonstration, and we did 5,000 people that Saturday. And we were just shocked that the kids were so interested and the parents were interested. And they picked up all the information that we had. We ran out of stuff. And the only thing we gave away was a candy cane. That was it. But this whole thing about hand washing and things like that, and we showed them what the germs look like when your hands are dirty, they really got into it. So that was really helpful. And we survived that day with those 5,000 people because they sent other volunteers to help us. The other picture is me and the head school nurse. We were at the homeless station, Skid Row, and there were so many tents, we literally barely could find a place to park the mobile van. Another one of those where those people in the far corner, they were there early because they heard we had snacks. And what we learned from this is when we did one of the vaccine clinics downtown, and it was a Saturday, the kids didn't get their free lunch or breakfast. We had kids fainting, and I was horrified. And the nurses said, Tracy, we don't usually come down to this area. And so what we did is everywhere we went, these little water bottles you see on the table, these stress balls, we literally got approval to go ahead and do little snack bags. And I can't tell you the line around the block again, but people got vaccinated. They brought their families. This particular mobile van team from St. John's does all adults and kids and homeless and everybody. So this worked out really well. And what people stood in line for was a $25 grocery card. If the kids got the catch-up vaccines, they got that grocery card. So we did have promotions. It raised the participation by 30 to 40%, only when the nurses did the outreach in advance. If we didn't do the outreach and we set up shop, we had a 10% or less participation rate. So you can't just give an incentive and think people are going to come. The other thing, these are the little snack bags. My whole house was full of these things because we packed them, and they were popular. And the nurses really got into this, and they sent out an alert to parents about holidays and having these gift bags if they got this vaccine. And you're thinking it's probably worth all of $10, but it was a huge plus. And the nurses were like, some of these parents don't ever call us back, and they did. So some of the things we learned by working together was it's the little things that do matter. And here's a interesting thing that happened. This other mobile van unit is called Coach for Kids, and it's sponsored by Cedars-Sinai. And they only do pediatric vaccines and other health screenings and things for kids, whereas the St. John's one will do adults. But this one is very successful. If you can see their promotion, they do it in Spanish and English. They tell you all the other things they offer, and they schedule it. So we knew exactly where they would be and when they would be somewhere. This is a very popular one because everything is customized to kids. When you go into the mobile van, everything is kid size. So people really like it. So at the end of the day, what were some of our key learnings? First of all, we did about 250 vaccines. And the funny thing about it was, despite the weather and everything, we rescheduled a lot of things. And the National Association of Nurses allowed us to continue because we had bought incentives based on our forecast. So we still have incentives that are being used today because we had to reschedule so much because of the weather. So we forecasted about 160. There were 20 kids per school that were legacy, non-compliant people when it came to vaccinations. And the incentives, like I said earlier, are a big thing. The other thing that was big is interactions. And interactions are everything from the nurses sending a letter. We had USC community outreach team that went into the field to those people's homes, that, you know, kids who were not coming to the vaccinated. And some of the principals and associate principals went with them. They did house calls, which I was amazed by, but that really showed engagement. The other learning that we have that's a big one is there were a lot of school staff that lived in those communities that also hadn't gotten vaccinated. We had quite a few adults get the COVID booster or the flu shot at our clinics where the St. John's one that does adults, and we didn't think about that. What do you do when there's a lot of people who live in that community and work at the school, in the janitorial, or in the cafeteria that are not vaccinated? Well, they also wanted to participate. So next time we do this, we really have to poll the school staff and try to line them up too. The last thing is, one school that was probably the poorest of the poor, we really needed to look at why people weren't participating. And one of the things was they were literally hungry, and people knew the kid would get sick if they got the vaccine. So in 2 cases, we got exceptions and we did food boxes. And the principals and the nurses and the associate principals worked together. And instead of stigmatizing the family, they had a private delivery of food. And the USC outreach team went to Food for Less, picked up all the groceries, boxed them, carted them, stacked them, and we put vaccine information in the boxes. And we didn't press them to get the vaccine, but that was something that they felt like we actually cared enough. And half of those folks did end up getting the vaccine. So there's something to be said for dealing with what people's needs are. If you're hungry and starving, you're not thinking about a vaccine. It's not that you don't want it. The other thing we were able to do about social determinants, there were people who had had their gas turned off, their water turned off, and the gas was big because I know my gas bill went from $20 to $700. So imagine what a person in one of those communities, their gas bill is like, right? So we were able to help triage some of those issues with other outreach support from other organizations we work with. And there's another organization called LA Children's Trust, and they manage all of the 17 or 20 plus that health clinics on properties at LA schools. They became a partner, and some of this information they already had, and they were able to support us, as did some of the nurses. So one of the important things was you can't do everything by yourself. It took 3 or 4 partners at a minimum to get this done, and to get it done as quickly as we could. And the thing that fascinated us, we looked back at our records to see what was the top requested vaccine. And Tdap a lot of the people were trying to go to the pharmacies, and I guess it's not a very common one. Maybe you pharmacists know. So they didn't have it necessarily. You had to call ahead. And then we see a lot of people now, we're getting a lot of requests for polio shots. So some of this was fascinating to us because we were just thinking, regular routine, but demand is high and we're getting more requests. So the question is, what are we going to do now? So some of the things that we're doing now is we learned that the nurses didn't necessarily have access to some of these resources. In California, we're fortunate there's a Shots for School portal. A lot of them didn't know about it. So quite a few new nurses and a lot of turnover. So we provided a lot of this information to them. We also provided links to things like videos. In the Spanish language communities, the videos they would show on their parents' portals or different places were the most popular information we could get out about vaccines. So having all these different resources that they could rotate through in the classroom after school on the parent portal. And they did use incentives, not incentives that we have, but from LA Children's Trust and other sources to get parents on the portals and to help them navigate it. Because a lot of the parents who didn't have internet went to the library to do the sign up. So they were very good about helping them navigate it. And so some of the other resources, like I said, this seems to be the most popular book, although we have a COVID-19 booklet that's very simple that Azita designed that is also very popular. But some of the other things, the letter had to be very simple and it just listed all the vaccines the kid needed and they were in different languages and the nurse would call ahead and then she would follow up. And then just visuals they showed around the school every day. Some were posters. They just wanted to remind parents when they were dropping their kids off or picking them up that they really needed to focus on this. So I'm trying to get one of the schools to do a mascot like this so we can have somebody on the street corner like you do when you're trying to see a apartment sale. And we think we'll get more kids to do the vaccinations when their parents drop off school. And so that's kind of our big learnings. I tried to keep it simple because it was hair on fire. I was all stressed out, as Azita knows, thinking, I don't know how we're going to get this done. Everything's happening all at once in LA. And so the fact that the nurses stayed the course, we are still engaged. There are still vaccine outreach going on in these underserved communities, particularly in the hard hit communities. And we found other resources to help those communities and principals that are beyond anything I could ever do, whether it's food delivery. They call it Fantastic Friday. Some of the organizations we work with are doing food delivery pickup every Friday in those communities because they do not want that to be one of the reasons that they don't take care of their health. And then we have Charles Drew University of Medicine and Science that has street medicine team that's out there helping support it, as well as USC has a community outreach team that's also doing that. And UCLA has a community outreach team. And I had to learn all these outreach teams because they're in different areas. They actually coordinate at times. So it's extremely valuable to have people from those communities who work in those communities who are aligned with getting this work done. And so that's it for me with the Champions for School Health. Kaiser was the main funder of the grant. They're actually looking at re-implementing this grant in a different way next year. But the fact that we're still working with all those organizations even more, and the schools are now aligned with the organizations, so maybe I can get out of the middle. It's been a very pleasurable thing to see the uptake. So that's it for me. Any questions? Yep, okay. All right. So we got it done. So if there are not any questions, all of these slides will be available probably in 24 to 48 hours with the recording. And if you do have questions, particularly those in Zoom land, and thanks Dr. Moore for managing the Zoom land issues we had. I want to make sure that people get all this information. And if there's anything we can do to support you, helping get uptake, education, outreach, we're here, okay? That's it for me. You guys can mix and mingle. Those in Zoom land can go take their stretch break. We're actually ending on time, early. I know it's shocking, but it's one of those things that happen so you guys can network, have tea, and stay around. And those on the phone, thank you all for staying the course for 3 hours. Take care.